Welcome, everyone, and thanks for joining us today for the International Myeloma Workshop Daily Update. I'm Mary Jerome, Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. I'm here in Boston with the MMRF this week for the next few days, attending one of the premier meetings specific to myeloma, the IMW. This meeting is held every other year, and it brings together renowned myeloma specialists from all over the world who present and discuss the latest advances in myeloma clinical research. I'm fortunate to be able to bring you updates from this meeting this year every day. Today, I'm joined by Dr. Irene Ghobrial, who's from the Dana-Farber Cancer Institute in Boston. Irene is going to be reviewing for us what's new with respect to patients with smoldering myeloma. Let's get started. Irene, today you were presenting at a session on myeloma precursor conditions like smoldering myeloma. And many of our listeners today and at some of our other events during the year have smoldering myeloma and always ask whether they should be treated.
Yeah,
is treatment possible? Or is it possible to determine who's at highest risk to progress to active myeloma and then maybe treat those patients?
That's a great question, Mary. And I think it is important for us to think, if I'm a patient coming in today and I have smoldering myeloma, should I decide on going on therapy, whether it's a clinical trial or standard of care, or should I wait until I have overt disease? And I think the first question that we always worry about is, what is my risk of progression to overt myeloma? Because the last thing I want is waiting until I have fractures in my bones, anemia, renal failure. What are we waiting for? And the word of watch and wait, a lot of my patients say it's watch and worry, which I agree. If I personally have now smoldering myeloma, I want to make sure that I get the best treatment to prevent progression, to prevent fractures and kidney failure. The problem that we have right now is the clinical markers that we use to predict who will progress and who will not are good but not good enough, meaning that we have a percentage of bone marrow cells, we have a light chain ratio, we have M-spike, but these are all markers of how much disease you have, how much tumor burden you have. What we need is biological markers of how fast the cells are growing, and will that predict for us what causes progression. So we are already developing multiple genomic markers, whether they're in the peripheral blood, liquid biopsy, or in the bone marrow, genetic, epigenetic, tumor microenvironment, asking a lot of questions to say, can I bring this to the patient next year? Can I say, you have this mutation and this alteration and your NK cells are not working well, and that combination tells me you will progress next year, while someone else who does not have a mutation and who does not have bad changes in their immune cells, they will not progress until 500 years from now. And that's important because the first question before I treat is, am I over-treating or under-treating certain patients? Two people may have smoldering myeloma. One of them will have a bad progression and should be treated. One person may not progress in their lifetime and should not be treated.
So you've started the Promis study to be able to determine some of these markers, correct?
Absolutely. So the Promis study is for the first time in the US. We're trying to ask the question, should I screen? I go to my primary care doctor and I'm over the age of 40 and I screen for mammography because I might have breast cancer. I screen with colonoscopy to prevent colon cancer. No one told me, why don't you give us your blood? A very simple thing, a blood test to see if I have multiple myeloma. And if I have a high risk of developing myeloma, meaning I'm African American, or I have a first degree relative who has myeloma, MGUS, or Waldenstrom, I'm at a 3 times higher chance of developing myeloma than the next person who's also at the age of 40 but does not have those risk factors. And wouldn't it be nice to know that I have a precursor condition? Not that it's nice, but wouldn't I want to know that I have this early precursor condition and potentially prevent it before I get diagnosed with myeloma? And just remember that every single patient with myeloma today, if I get diagnosed with myeloma, I was supposed to be diagnosed with MGUS and smoldering, but no one looked for it. Every single patient with myeloma had a precursor condition of MGUS and smoldering, but because we don't look for it, we don't diagnose it. And the hope is that we diagnose every single patient at MGUS or at smoldering, we prevent it, and we never see myeloma happening in the future.
So I think a lot of your work has really helped to elevate the conversation in the myeloma community around smoldering, which is great because there's a lot of our patients, as you said, don't want to wait and worry. So what is some of the newer data that's come out in the myeloma community about treating patients with smoldering? And there's been some talk of that here at IMW and also a lot at ASH back in December.
Yeah, absolutely. I think the question is now what do I treat them with, right? So if we decide to treat the patients, what do you use for treatment? And there were 2 large randomized phase 3 studies that were done. One in the Spanish group that showed that lenalidomide and dexamethasone versus observation was much better in progression-free survival, meaning preventing you from developing myeloma, and in overall survival. Now that was wonderful because it was the first time ever we showed that you can make a difference by treating early. The problem why we never used that data in the US was it's slightly different how we treat patients in the US compared to Europe. And some of those patients may have had active myeloma because in the old days, we only did skeletal surveys and we did not do MRIs or PET-CT scans. Recently, the ECOG study showed that lenalidomide alone until progression was much better in progression-free survival compared to observation. So that was also amazing because it's the second study to show a difference. Yes, we should treat early. The problem with that study is we don't know which subgroup of patients may truly benefit because there was low risk, high risk, and intermediate risk in patients. And treating until progression may not be the best answer for us because we don't want to cause secondary leukemias. We don't want patients to have treatment for 7, 8, 9 years and to prevent progression. So we need something else. We need to improve on this. I think these are the first perfectly good trials. Let's improve on that and get better and better in our treatment. So the answer is there are so many clinical trials ongoing. There are so many efforts to try and have what I call precision prevention. We will actually have better, improved treatments for our patients. And instead of treating everyone the same way, let's actually have a subgroup of patients treated in a specific way to get the best response for them.
So just tell us a little bit about some of the work going on right now to really try to define who is the high-risk population in smoldering patients.
I think there are a few things that we can ask who is really supposed to be treated. And one of them is the genetics that we know so far. So even by cytogenetics in fish, we know that these are bad players, 17p deletion, 1q amplification, p53 mutation. We know some of that. We know MYC amplifications and translocations are bad. That's already known. We know that certain patients may have a really suppressed immune system, and we need to define that slightly better than what we currently say, but that should also be added into the mixture. But even if you just look at the genetics, even today, can we define who will be very high risk biologically? At least the bad cytogenetic players should be put into a different group of patients and should be treated slightly different.
Yeah. And I think that's true not only for smoldering myeloma, but for symptomatic myeloma as well.
Absolutely.
So, and certainly immunotherapy has been getting a lot of press lately in cancer and in myeloma as well. And if you add that sort of treatment, such as Darzalex or even a CAR T treatment, would these potentially be useful for smoldering myeloma patients in the future?
So daratumumab has been tested already in smoldering myeloma. There are multiple clinical trials. Originally a phase 2 and then a phase 3 study was completed. So we will hopefully get to know the answer whether dara versus observation makes a difference in smoldering myeloma. And we even went earlier in high-risk MGUS and low-risk smoldering with single-agent daratumumab. There are so many clinical trials adding dara already into the mixture of the combination of therapy. So dara-lendex, dara-RVD is something that we're thinking of doing in the future. All of these are options of adding daratumumab early. I think CAR T is a great example of something that if it was less toxic and if it can be used in the right way, can we bring it earlier? But the idea of immunotherapy is an absolute yes. I think that's the way to potentially cure myeloma is by early interception with immunotherapy. And that includes vaccines, checkpoint inhibitors in the future if they work well, other immunotherapies, bispecifics, CAR T. Everything is open as long as it's not toxic, it's not for a long duration, and it targets the right population of patients.
So I know it's still early in the meeting, and today was really only the first full day of the meeting, but in the sessions that you've attended, in the sessions that you've spoken in, can you see any themes that are coming out about anything that patients might find to be actionable as they're talking to their care teams about their specific myeloma and their patient journey.
Yeah, absolutely. Today was wonderful and exciting to see all the new data come along, but also the collaborations and interactions we have. I think we heard so much about new genomic data of how clonal evolution happens. We heard a lot about the immune microenvironment and that we're not focusing only on the cancer cells, but on the immune cells and the tumor microenvironment. We heard a lot about the microbiome. That was actually a very interesting thing, that potentially that plays a role in our immune system and how not only the microenvironment in the bone marrow, but the macro environment of our whole body is important in helping or hurting or being permissive or non-permissive to allow progression or to allow response to therapy. And then we heard about new options of therapy in the upfront setting, in the relapse setting, as well as maintenance. And then the question of MRD, can we use MRD as a true surrogate of long remission, of long survival? And I think all of this was only in the first day. So yes, absolutely exciting time for all our patients. As you know, myeloma keeps changing every day, and that's the exciting part of it. I started working in myeloma 15 years ago when Vince Rajkumar was still starting the thalidomide versus dexamethasone studies. So for us to come here and have all these options of therapy and how to use them in combination and when to use them and having different endpoints all the time is exciting, not just for us, but much more important for our patients. They're the ones who see that benefit translated to them every single day.
That's great. So I think that from our discussion, what we've seen is that genomics are going to be playing a key role in the definition of what a high-risk smoldering myeloma patient looks like and whether or not these patients would benefit from certain treatments that are not currently being used, potentially immunotherapies. And we've heard a lot about what therapies are currently in clinical trials for smoldering myeloma. So I think for smoldering myeloma patients, this meeting in particular is offering a lot of hope and a lot of really exciting information for them. So thank you so much, Irene, for being with us today. And I look forward, as I'm sure that you do, for the rest of the meeting this week and all the great things we're going to learn. So thank you.
Absolutely, thank you.
Great. So today I'm joined by Dr. Paul Richardson, who is from the Dana-Farber Cancer Institute and one of the organizers, actually one of the co-chairs of this year's IMW in Boston. So Paul is going to be reviewing with us what's new with myeloma diagnosis and management and a couple of other hot topics in myeloma. So let's get started, Paul.
Well, thank you so much, Mary. It's a pleasure to be here. I have to say it's been quite the beginning.
It has been.
The first day was marked by, I think, what was beautifully organized by my co-chair, Stephen Treon, which was the introduction to the meeting with a very historical flavor, and then some wonderful orchestral, or not orchestral, but some choral singing by the Harvard Gin and Tonics, which I think was really actually very light-hearted. It was lovely. But I think what was a highlight was actually a wonderful introduction and welcome from the mayor,
yes,
which I really thought was quite something,
yes,
actually.
And he is himself a cancer survivor,
Absolutely.
Right?
So a fabulous man, and at the same time, he developed Burkitt's lymphoma as a boy, and was treated at Dana-Farber actually, and did really well, and now has gone on to become a really super mayor and very popular in Boston, and has done a great job. So it was particularly nice to have him, and I thought his opening speech kind of set the tone for everything. But it was also really nice to have a historical perspective, which was beautifully set up by Dr. Bob Kyle and built upon, and Jesus Miguel gave a beautiful presentation. So a very good start to the whole meeting, and a whole series of incredibly interesting sessions followed, for sure.
Yes, absolutely. So speaking of sessions, the
Right.
session that you chaired earlier today was talking about myeloma diagnosis as well as treatment approaches. So I wanted to start with a question about myeloma diagnosis. So can you tell us if there's anything new regarding diagnostic tests for patients? Particularly, our audience wants to know what alternatives exist to the dreaded bone marrow biopsy.
Well, yes, in the diagnostic session, I mean, obviously there's a lot of new and exciting research being done to try and limit or minimize the invasiveness of the testing that we do. I would stress that obviously there are tests that can be done simply from blood samples that can be very informative. Whether or not they will replace bone marrow aspirate and biopsy for the reliability of information that we get from it, I think kind of remains to be seen, because it's not just diagnostic information that one gets from a marrow relevant to the myeloma, but it's also diagnostic information about the patient as a whole, not least of which is their cellularity of the bone marrow, and therefore how well they're likely to tolerate treatment, and actually also intercurrent problems we often find, not often, but from time to time we'll find on a bone marrow. So I think some exciting stuff in the diagnostics. But to speak to really where I was able to sort of concentrate was in the treatment section, Mary. And I thought there we had an extraordinary afternoon, actually, and covered a lot of ground. Obviously, I was very fortunate to co-chair with Mary V. Mateus, she's a super researcher and clinical leader in Spain, and actually recently honored at the European Hematology Association with a very prestigious award for her work. So anyway, we chaired a session looking at newly diagnosed patients and their management and the relapse refractory setting. So I'm very happy to sort of start, if I may, just by sharing what the takeaways in the newly diagnosed setting were. Dr. Michele Carvo talked to us about transplant-eligible patients, and very much a European perspective on their management. And it has to be remembered in Europe, the paradigm of care is induction remission therapy. And if you're young, you receive an autologous transplant, and then maintenance has sort of now become a standard of care, but relatively recently. And I think that was really the focus of his talk. I think it was very informative, but I think it's very important for listeners and viewers to note that in Europe, there is a strategy that's built because in the salvage setting, the availability of salvage options for patients is more limited than we have here in the United States. And I think whilst it's improving all the time, it's not where we're fortunate enough to be. And so as a result of that, there's a somewhat different philosophy there. But I nonetheless found Dr. Carvo's presentation on the transplant-eligible population really informative. He really focused on the role of the 3-drug platform, the advent of antibodies, what that will mean, and how that will influence the use of stem cell transplantation. And obviously in the European setting, their ability to use the tandem approach is another thing they're very fond of.
I thought that data was particularly interesting, and the difference between having one bone marrow transplant versus a tandem transplant or having 2 transplants.
Yeah, and I think, again, the German data are positive, but in the US, our data are not. They don't show an advantage to it. And I think that what we mustn't forget is the patient. And at the end of the day, quality of life and side effects really matter. And I think that the best data we have in autologous transplant, looking at quality of life, shows that compared to non-transplant approaches, there is a substantial drop in quality of life across the transplant period. And certainly in that context, whilst it does correct over time, we have to be absolutely sure that what we're doing is really necessary and really going to result in a clinical benefit. And what Michele shared was there's lots of progression-free survival benefit, but actually, very consistently across the trials, there's no overall survival benefit for doing an early transplant versus a late. So the conclusions were really quite interesting, because certainly from a US perspective, we love to give our patients choices. And in the European setting, really the more the interpretation was, well, it remains a standard of care to do a transplant early. I suspect largely because when patients then unfortunately ultimately relapse, the ability to offer salvage options and to have more flexibility around treatment choices may be less. But nonetheless, it was very informative from Michele. I found, to be honest, the presentation from Dr. Thierry Facon particularly good. This was looking at the non-transplant population, and Thierry presented a beautiful overview for non-transplant eligible patients, really how exciting it's become for older patients to receive 3 and even 4 drug platforms, but do so in a way that's highly tolerable and to see real clinical benefit and the kinds of outcomes from relatively tailored regimens that we used to only see in younger patients. So it was really nice to see median progression-free survivals of 4 or 5 years to initial therapy. Amazing in the older population. So really nice data. And of course, we haven't even reached the median with a combination of daratumumab, lenalidomide, and dexamethasone, the so-called MAIA trial. One interesting question that was put, and I thought put very nicely to Thierry by Mary V, was daratumumab, lenalidomide, and dexamethasone for older patients, clearly very well tolerated, very effective. Then the question goes about risk. And so the issue is to be more tailored. So how can we tailor therapy to meet a high-risk patient need? And in a high-risk patient with 17p deletion, would you just do daratumumab and lenalidomide and dex, or might you add a proteasome inhibitor such as bortezomib to enhance your protection against 17p. And that clearly is now feasible for the older patient, with a tailored regimen that you could even theoretically put all 4 drugs together for them.
I thought he made a particularly good point, showing the data that it was so important to get the right therapy to patients who were more fragile, older patients. The first therapy that they took has to be the exact right therapy, because it really helps their outcomes.
I completely agree with you, Mary. I think that was one of the biggest takeaways, is that once you move into the relapsed and relapsed refractory setting, it truly becomes much more challenging to successfully salvage patients, and particularly in the older, frailer population.
So, So what about newly diagnosed patients and the therapy options there?
Well, those are the ones we just covered on, Mary, on the from Michele Carvo's presentation and from Thierry Facon. But to build on your point, Ed Stadtmauer presented very nice data on what consolidation may or may not add to the transplant paradigm, and I thought it was very fair, and it was really a focus on what is the science behind it, what does it do. And actually, its feasibility, particularly after transplant, where patients need time to recover and restore their quality of life. I think the important message there was it probably has a role, but it's definitely a conversation with your provider, with your physician, to decide how much is enough and whether you need it or not. I think that then rolled very nicely into the maintenance presentation by Dr. Phil McCarthy, which was a highly informative lecture, somewhat information dense, I have to say, in the sense that Phil was brilliant at putting so much together. But the takeaways were lenalidomide maintenance until progression, that we can build on lenalidomide maintenance successfully, that in higher risk patients, drugs like proteasome inhibitors matter, and that these can be drugs like bortezomib. They can be important, very convenient, well-tolerated drugs like ixazomib. And similarly, of course, in a high-risk patient who's younger and more robust, you might think about carfilzomib-based therapy as well, or rather, as the alternative approach. But then also, very importantly, in maintenance, the antibodies, what role will they have? So the maintenance discussion I thought was very interesting. And then we rolled into, well, okay, when maintenance fails, which has made an enormous difference in terms of outcome, years of survival gain, when that fails, and when that fails a patient, what do we then salvage? And emblematic of the times, I think Philippe put close to 40 slides into 10 minutes.
Sounds like somebody else I know.
Well, yes. So that's why actually I was going to say, you're very kind to say that, Mary, because that's why a few people looked at me, because I let him absolutely finish, because what he had to say was helpful. It was really good, and it was very informative. But he did it. So we were able to get lots of information from Philippe. And really the takeaways were the relapsed refractory space is very, very busy. There's lots of damn good options. And sequencing is real. You can salvage with a pomalidomide-based regimen in first relapse. You can then move to next lines of therapy after that. And outcomes are getting better in the relapse setting compared to where we were, with some outcomes that are dramatic. He also touched on, obviously, some of the newer directions. And that was actually very nice, too, because that then segued very nicely to Sagalonial's presentation, where he talked about the management of the relapsed refractory patient in whom, all other classes of drug had failed them. So what do you do? That's a tough area. It's a very tough area, but we had a very good discussion on, obviously, selinexor, which has just been approved. And Saga showed some very nice slides on the combinations and how well the selinexor combinations have performed, particularly with proteasome inhibitors, where if you dose the drug once weekly with bortezomib-based therapy or carfilzomib, the results are excellent. And the tolerability profile appears to dramatically improve. And also the tolerability is manageable. It's challenging, and you have to work hard. But there's no doubt that the nausea and the fatigue and all of those things can be so debilitating to a patient, including the anorexia, can be managed with supportive care, and particularly in combination. Because at the end of the day, why would we go to all this trouble? Well, because actually there is clear activity. And Saga prefaced his conversation by saying, when you see complete remissions in penta-refractory, triple-class resistant patient population, you listen. And sure enough, there were CRs in the Storm 2 trial which reflect that kind of interest in the drug. Having said that, we've got a lot to learn and a lot to do with it, but I'm very hopeful that will make a difference. Not least of which because it's a completely new class of drug, and it works in such a novel way that it works on a mechanism that we've hitherto never been able to target. So
yes,
I think that bodes well.
And he did talk at the end, or during his presentation, about some of the drugs that are currently in trials, like the MCL1 inhibitor and some of these newer classes, like the novel agents. So
sure.
I thought that his final point, which was really to make sure that patients were aware of clinical trials and that they knew what was available to them, was so important.
Yes, it is, and I think that's exactly right, because that's the bridge that gets the patient to the next step, potentially. But the challenge we face, as we had in the discussion, was this is a very vulnerable population, and so how do you build clinical trials that the regulatory authorities will find robust enough to allow you to do them? Because eligibility is, obviously very important from a safety point of view, but from a patient perspective, it can be a barrier. It can deny you access to a potentially very promising drug. So that was a point of discussion. How do we build trials that are real world and reflect what we really need to do for our patients? Because of all the patient groups who need this, it is this group of patients because they're in real trouble. And I think that's a very interesting area. So I'm very glad that came up, because at the workshop we have not only our industry partners and obviously investigators from all around the world, but we also have our regulators here. Which is particularly nice, actually.
Yes.
So they can hear all the discussion.
Right. So let's step back a little bit to transplant. Right?
Yeah.
So one of the things I wanted to ask you is that you talked about how here in the States you like to give patients choices.
Yes.
So, and we know that there are patients who want to have a transplant right away up front, and then there are some who would really prefer to wait.
Yeah.
So when patients come to you with that question, how do you answer them?
Well, it's a great question, Mary. I think it's very individual, and I think let's talk about the data, because the data are actually very important to frame, because they are changing very quickly. And what I was a little bit surprised, because we had this panel of colleagues who are brilliant in autologous transplant, but it was somewhat, it was very European. It was chaired by, obviously, Sonja Wiegman. I want to get that right. She's really nice, but she's Dutch-based. And, of course, all the panel members, except one, were European. And one of the panel members who was US was David Siegel, who's a wonderful guy, but transplant is absolutely his mantra. So there was not, as it were, an alternative view. But what was interesting was even amongst that sort of very transplant-focused group, there was an acknowledgement that, to your point, Mary, if a patient did actually say, look, you know what, I'd like to keep this in reserve, the data support it. Why? Because there's no survival difference to late versus early transplant seen in a number of randomized trials. Not just one, but several now. So there the clear signal lies. And the thing is, if you have a triplet-based therapy, especially it seems the combination of carfilzomib, lenalidomide, and dexamethasone as one very important platform, you probably can keep transplant in reserve, provided you have a high quality of response. And I think what's really nice was one of the panelists was particularly good, Francesca Gay. She's the leader of the Forte trial in Italy. And as she discussed, in Italy, you don't have necessarily the access to salvage options that we have in the US. So she's therefore a proponent of earlier transplant, but her own data clearly support the fact that in patients, particularly with standard risk, it can be kept in reserve. And also what was so interesting was a great question from the audience from actually Dr. Nupa Rajay, where Nupa pointed out to Francesca that in the data she presented, which showed possibly earlier relapse in the non-transplanted high-risk patients, these outcomes were blinded to what maintenance they were on, because that part of the study has not been analyzed and opened. So that's actually a key point, because if you're not using optimal maintenance in a high-risk patient, well, not perhaps surprising that perhaps disease control is suboptimal. So I think the conclusion of the conversations at this panel were quite good, actually. One, that whilst it was a very pro-transplant panel, there were sufficient questions from the audience to sort of say, actually one size doesn't fit all and you can have choices. And second, there was a very important acknowledgement about toxicities, that there really is a side effect issue we need to be aware of for our patients. There is a loss of quality of life across transplant. And whilst there's a lot of very well done efforts to manage side effects, at the same time, it is in reality what it is, that this is a major interruption and disruption to a patient's life. And I think the last one that is important, it's an important clarification, is that it's an excellent question from the audience, because there was an implication from Dr. Siegel that secondary leukemias and MDS came from lenalidomide, and really the transplant wasn't the point. That's really not true based on the data. The reality, there are actually, the questioner said, there are 13 randomized studies that show clearly that the driver of the signal, not just in transplant but in non-transplant patients, comes from the melphalan. So if that's the case, you know, it's clearly not the lenalidomide that's driving it. Maybe adding to it, but not driving it. So I think when you think of things like that, where are we going with this, Mary? Well, where we're going is we can't just ignore that information. We have to say, if there's a secondary leukemia and MDS risk, how do we protect people from that? How do we make sure we don't expose those patients who are vulnerable to that to transplant? Because they probably shouldn't have it if they're at risk of this complication. Of course they shouldn't. Secondary AML is very challenging, lethal actually. So I think the takeaway from that is that we need to get more tailored. And one piece of very interesting information in that regard is that there may be this thing called clonal hematopoiesis of indeterminate potential, or CHIP, which may be more common in myeloma than we appreciated. And from lovely work from my colleague, Dr. Irene Ghobrial, Irene's group have shown that actually the rate of secondary leukemia MDS may be much higher in that group. So if that's the case, they may be the folks you don't want to take to high-dose therapy, or keep it in reserve at least, and others may be safer. So there's stuff like that that I think is going to really help the debate. So I think you know, it was a great discussion. European perspective, transplant. US perspective, one size does not fit all. Fortunately, our patients have choices. And then I think the third one of the debating conversation, Mary, was the discussion about allo transplant. And that, I think, remains very much an experimental space. I think a very healthy discussion around that, as we talked about earlier, but I think allo transplant remains definitely the purview of protocols only. And with the excitement around things like CAR T therapy and the immunological strategies, I'm really not sure that allo, I think allogeneic transplant will remain a niche space for myeloma patients, for sure. It's my own feeling. And that certainly wasn't just my own. Dr. Sagalonia was asked the question in the panel, and he said flat out, there is no future for allo in his opinion. And I understand why he says it.
Really interesting for patients.
Yes,
definitely.
absolutely.
And so actionable. In the few minutes we have left, let's talk a little bit about what has become a hot topic a little bit here at this meeting, which is the microbiome and its role in myeloma.
Yeah. Well, I'm very glad you asked that, Mary, because that I thought was fascinating. So essentially, in terms of the microbiome, we've realized how important that is in all sorts of disease states, and how important it is in oncology broadly, because the first observation was that in solid tumors, responses to checkpoint inhibitors were influenced by the patient's microbiome. And also in the allogeneic space, in allotransplant, where, please don't misunderstand me, allogeneic transplant clearly is a treatment of choice in so many other blood cancers, just one to be approached with caution in my view in myeloma. But in the allo space, there was this observation that the microbiome influenced graft-versus-host disease. So because of that, and because of the observation of the influence on the responses to immune checkpoint inhibitors, there's been a tremendous amount of interest in the microbiome and how, as an inflammatory platform, that influences outcome for our patients. And we see it in lots of different ways. I mean, for example, with lenalidomide, for example, maintenance, we've always seen this almost irritable bowel syndrome that may in fact have an inflammatory basis to it. And manageable, but may in fact reflect truly some form of immunological effect of the len, which is relevant. So lots of microbiome evidence that we have to sort of think about. The thing that I found so interesting at the presentation today, and thank you for raising it, was really nice work from Leif Berksagel, which was done in a mouse model. And what this showed was that in mice, he has his American mice, and his partners and collaborators have Italian mice. And this is quite serious. There's a difference in their microbiomes and how their myeloma behaves. What was so interesting was that if you were one of these unfortunate American mice, things sort of moved along more quickly in the model to myeloma. Whereas if you're one of the Italian mice, things went much more slowly. So the interesting question was why? And actually that was dissected very carefully and found to have a true immunological basis, in particular through a pathway modulated by basically in an IL-17 positive ontogeny of immune effectors. So this basically raises a really interesting question of how in manipulating the microbiome may improve outcome. Now, I think it's highly speculative, very early, but you might say, well, how on earth do you act on that as a patient? Well, a couple of things. I think you sort of live green if you can. There was a very funny comment from Irene about drinking red wine, because of course that's something you do in Italy, perhaps more than here, I don't know. But that obviously is a different matter. But I think what was really interesting is there's a true concept that diet and microbial manipulation may change things. There was some tantalizing data from the Europeans, actually British to be precise, looking at the role of antibiotics in early diagnosis of myeloma and reducing complications and impacting on survival. And it's possible that the use of those antibiotics has a different effect as well, because it reduces this inflammatory stress that drives the myeloma. So my takeaway is inflammation is not good for you. Anything you can do to cut it down makes sense. And there was one last thing, which is true. In the rat model, or not the rat, I apologize, the mouse models, if the mice were obese, their myeloma progressed more rapidly. So easier said than done, but there's no doubt if you can keep your weight down, I wonder.
Right. I think that there has been some data published on that in people.
Oh,
as well.
Absolutely. No, you're absolutely right. So no, that is quite true, both in men and women, actually. But what hadn't been shown, what wasn't known until today, of course, was Leaf's data where he's looked at this, making these mice plump.
The obese mice that could only fit 2 in a cage.
He did, and described them as rather greasy.
Greasy.
So poor mice, but anyway.
Yeah, I know.
But it was very funny. So, mice and men, as the saying goes.
I guess.
Yes, right.
Okay, so, this has been a pretty wide-ranging conversation,
It has.
right? And we've gone all the way
Yes.
from treatments for newly diagnosed patients to maintenance therapy, consolidation, to treatments for relapsed refractory
Yes.
patients. Talked a lot about transplant and about the microbiome as well. And the microbiome, I think, is a fascinating topic. And I think
agree.
it's fascinating, and it actually has implications in every area of health. So it's really interesting to see how that's developing here, in myeloma. So.
Well, I think it raises a very important point, Mary, which is a holistic approach. And I think that we must embrace that, because I think that's also what's came up in the debates today. There was a discussion about, I want to, literally, I think, what did David say? He wanted to drive that MRD negative response. I want to hammer a response for my patient. I thought like saying, well, guys, let's take a deep breath here. Is the argument no pain, no gain? I don't think that's true at all. I think it's the opposite, actually. I think no pain, gain. So I think that's a message of all of this, that side effects really matter, that a holistic approach really matters, thinking more imaginatively and thinking about how all our treatments interact and how supportive care is very important. All these things matter.
Sure. And it's very true that patients really need to make clear to their care teams
Right.
what their goals are, right? And there are some patients who really do want to use the hammer to knock their disease down, whereas some are really more interested in maintaining quality of life for
Yes.
various reasons and not being debilitated by their treatment. So it's a very important point.
And the beautiful thing is, Mary, we have, as opposed in the old days where we had a relative therapeutic paucity in terms of options, now we're in a very different space. We have so many options. And actually some are both. They're both highly effective at reducing disease burden and controlling disease without a side effect profile that's just so challenging that it becomes a problem in itself.
Sure. So thank you so much for being with us here today, Paul. The meeting is only one day so far, and we still have 2 or 3 more really exciting days to go. We're going to learn a lot more. So really looking forward to it, and thank you for being here with us today and helping us summarize what's happened on day 1. We appreciate it.
It's my pleasure, Mary, and thank you very much for inviting me.
Great.
Thank you.
On behalf of the MMRF, I'd like to thank Dr. Irene Ghobrial and Dr. Paul Richardson for being with us today on this busy but exciting time here at IMW in Boston. I'd also like to thank everyone watching this update. Finally, I'd like to thank our sponsors, AbbVie, Amgen, Bristol Myers Squibb, Celgene, Cure Magazine, Genentech, GlaxoSmithKline, Janssen, Karyopharm, Novartis, Sanofi, and Takeda Oncology for sponsoring these daily updates. This video from this session will be available soon on our website. If you have additional questions about what you heard today, Please call our nurses at our MMRF Patient Navigation Center. Their number is 1-888-841-MMRF, which is 6673. Please be sure to check back in with us tomorrow, and I'll be speaking to Dr. Jesus Berdeja and Dr. Amrita Krishnan, and we'll be talking about their perspectives on the latest treatments for newly diagnosed patients and what's new in immunotherapy in myeloma. Have a lovely evening, and thank you.